Okay, my name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan. And this evening's Learn and Share conference call is entitled Epilepsy Beyond the Nervous System. And we're very pleased to have with us Dr. Deepti Zutshi, who is an epileptologist with DMC Harper University Hospital and Wayne State University. Thank you so much for joining us. Can you give us a brief overview of your clinical and research interests and your experience with this topic?
Sure. First of all, good evening, everyone. I hope everyone can, I should have tested before we went mute, that everyone can hear me clearly today. Thank you very much for inviting me, Russ, as always. So my name, as Russ had mentioned, is Deepti Zutshi, and I do work at Wayne State and Detroit Medical Center's Comprehensive Epilepsy Center. I specifically specialize in epilepsy in adults. My own special interests include women's issue in epilepsy and neurology. And I also am involved in a subspecialty clinic in high-risk epilepsy and pregnancy cases, which we're going to talk about a little bit later today. And this includes planning, treatment, evaluations during pregnancy, postpartum care. As far as research goes, I am interested in, like I said, the pregnancy and epilepsy side, specifically looking at transgenicity as well as some of the issues that women who are pregnant and have epilepsy face, specifically in Detroit, in an urban area. And I also do quite a bit of electroencephalography research in status epilepticus as well as hypothermia as well.
Okay, great. So the topic today, I think everyone understands that epilepsy is a disorder of the central nervous system, and what's less understood is the impact that epilepsy and its treatment can have on other bodily systems, and also the influence of these other systems on epilepsy. So that's what we're going to discuss today is epilepsy, what happens once you get outside of the nervous system. So to get us started, can you give us just a really quick overview like an Anatomy 101 of the different bodily systems and what they do?
Okay, I'm going to do my best to give you a quick overview of everything.
Exactly.
So to start out with, the nervous system is divided into two parts. There's the central nervous system, which you know involves the brain and the spinal cord, and these organs basically take input from our peripheral nervous system, which consists of our, peripheral nerve sensory organs. They interpret the signals, process the response, and then send signals back and forth between the brain and spinal cord to the peripheral nerves and organs to do what we want. There are conscious parts of the system, so those that when we want to pick up a glass of water, for example, we're consciously thinking of that. And then there are also subconscious parts of the central nervous system, such as parts that regulate our breathing and blood pressure, and et cetera. The next system that is important is cardiovascular system. So the cardiovascular system basically involves the heart as well as the blood vessels in our bodies. These organs are the plumbing system. For example, they basically take in good nutrients, circulate them to all of our organs, and remove bad nutrients and carry them to where they can be removed or filtered out of the body. For example, this is how blood through the circulatory system will exchange carbon dioxide via the lungs, toxin via the kidneys and the liver. The skeletal system works to form our body structure. We basically need a scaffold to move about, otherwise we would be no better than amoebas or slugs, and this gives us shape. The bones also contain bone marrow that is important in housing parts of the hematopoietic system. So this is the system that makes our blood cells, and this is housed in our bones. And this is where we form blood, clotting factors, some of the immune cells we use to fight infections. And the bones are also very important in storing minerals such as calcium that is very important in other functions. The muscular system makes our body go. Beyond the obvious muscles that we use to move our skeleton, there are muscles that are in most of our organs that help move things internally, such as our tongue, the esophagus, parts of our intestine. All of these things are made of different variations of muscle. Even the fact that our pupils dilate are controlled by specialized muscles. The respiratory system acts as a gas exchange. It brings in oxygen and takes out carbon dioxide. We require this oxygen in the creation of energy that is used by all of our living cells to make them work the way they do. The digestive system is how we get the rest of our energy nutrients. While oxygen gives us one of the nutrients to give cells an energy, they require sugars and other nutrients to make the rest of it. So we gain other nutrients through digestion, such as protein, minerals, and vitamins that are in our food, and we break it down to essential nutrients that are easily absorbed by our bloodstream. It also removes our waste that we don't need to help our body remove toxins. Other organs that are considered part of the digestive system are included, besides the intestines and the gut and stomach, include the liver and the pancreas. And these organs are support organs that help the breakdown of nutrients so that we can take them in and use them. Okay. The urinary system, which is the kidneys, the bladder, the ureters, is another filtration system for the blood. It takes out excessive amounts of minerals that we might not need, toxins that we put in our body, and also produces compounds that help regulate our blood pressure and cardiovascular system. The endocrine system is made up of a variety of glands in our brain and other parts of the body, and this regulates the body's homeostasis. This word is going to come up a lot more later tonight. Homeostasis is the body's ability to maintain an internal balance, such as in relationship to temperature, pH, oxygen, even sleep. Glands that are involved include the pituitary gland, sitting in the brain, the thyroid gland and the parathyroid gland sitting in the neck, and the adrenal glands. These are some of the examples. Okay. The immune and lymphatic system are involved in helping our body fight off infections and unwanted parasites. So this is bacteria or otherwise. The lymphatic system is a way for removal of dead cells and debris from our body to re-enter the circulatory system so that it can be filtered out of the bloodstream. Examples of the lymphatic system are lymph nodes that make certain types of immune cells, the spleen and the thymus. The immune system is made of other types of white blood cells and is involved in inflammation to help the body fight infections. The integumentary system, or the skin, basically provides the barrier to keep the body from becoming infected. It also helps excrete waste, such as sweat, provides temperature regulation, which is shivering, and is a sensory organ in that it detects pain, temperature, and pressure that is directly connected to muscles and nerves that then go back into the central nervous system and give us feedback about our environment. Okay. And kind of lastly, the reproductive system is the genital organs that work towards sexual reproduction, but they're also important in producing hormones and chemicals that are important in homeostasis.
Okay, very good. Well done. That was a lot to cover. So now that we've covered that, we kind of have an idea of the wide variety of different systems that are out there and that are involved in living, basically, and how those are we'll talk a little bit how those might be affected by epilepsy and how they might influence epilepsy. So let's start by talking about generalized tonic-clonic seizures, because those are perhaps the most dramatic example of how epilepsy can affect other bodily systems. So can you explain what happens in the body before, during, and after a tonic-clonic seizure, including potential injuries and complications, any kind of changes in the heart rate, hormonal changes, things like that? So if you can just talk a little bit more about what's involved in that and how the different systems of the body are involved in a tonic-clonic seizure.
Sure, absolutely. So to begin with, I think it's very important that everyone realize what a generalized tonic-clonic seizure is. Generalized tonic-clonic seizures, or grand mal seizures, back when that was the first name given back in 1981 in the classification system, are seizures where the whole body has initially a tonic phase, where the body becomes clenched, whether it's with the arms extended or flexed, and then this is followed usually by a clonic phase, which is rhythmic muscle activity. A generalized tonic-clonic seizure can be seen in various different types of epilepsies, and this is important because to answer your question, you kind of have to realize that the different types of epilepsies may start differently. So there's focal seizures that they start in one part of the brain and then have a secondary generalized tonic-clonic seizure. And then there are those patients who have primary generalized epilepsy, where the seizure starts from everywhere in the brain at once. And they can also have something that looks basically like a generalized tonic-clonic seizure. So when you say generalized tonic-clonic seizure, you have to understand that that is just the physical description of the seizure, but it actually doesn't tell you where the seizure is coming from at all. And that is all dependent upon electroencephalography work. So the reason this is important is because the seizure begins is a focal seizure, and it begins in one part of the brain. Then the effect on the body may be determined by where the seizure begins. So an example of this is if you have a seizure that starts, for example, in the non-dominant, meaning so most of us are language dominant left, even if we're right-handed or left-handed, it may become in the non-dominant insular cortex, which is a part of the brain near the temporal lobe. Patients who have seizures that start here may experience vomiting during the seizure, and then they'll have the generalized tonic-clonic seizure afterwards. These types of seizures can be associated with slowing of the digestive system, for example, as well. So even though they might have a generalized tonic-clonic seizure later, the fact that they even started with the seizure in one part of the brain and then it spreads can definitely affect what you will see or what they may experience. Right. Patients who have seizures in the occipital lobe may experience visual hallucinations or shapes or different changes in colors because of where the seizure starts. Now, speaking about the generalized tonic-clonic part of it, we do know that in the course or even at the start of these type of seizures, whether they're focal or they start out immediately into a generalized tonic-clonic seizure, which may happen, we know that epileptic seizures can interfere with the cardiovascular and respiratory system. That is often the scariest part. Right. Specifically, we can see patients have cardiac arrhythmias. They generally have a speed up in their heart rate, and the breathing patterns can also be affected. This can lead to symptoms such as shortness of breath, coughing, choking. That's why it's important to turn patients onto their side to give them the ability to let them breathe. Furthermore, changes in these organs are related to heart disease and stroke in the long term. So one of the things that we're going to talk about a little later is something called SUDEP, or sudden unexpected death in epilepsy. And this is thought to be related to these changes in the cardiovascular and respiratory system. And we'll talk about that a little bit more later, I think. Okay. The muscular system is affected, has a misfire, is affected as well, obviously, because during a generalized tonic-clonic seizure, the motor cortex, which is involved in controlling our conscious muscle movement, is misfiring, and it will send signals down the motor pathways to make the muscles move. Sometimes this can be a loss of muscle tone, so that they can cause falling. And this can be seen as drop attacks or atonic, spelled A-T-O-N-I-C, seizures that can be seen in certain types of epilepsy, such as Lennox-Gastaut. Other types, it can cause intense stiffening, such as around the vocal cords, and that spasm around the vocal cords associated with the breathing problems can cause that initial screaming that sometimes patients will have with the generalized tonic-clonic seizure. There's a lot of soreness after generalized tonic-clonic seizure. I have patients tell me all the time that they are sore for even not just hours but days. And it is not uncommon for patients to fall and have musculoskeletal injuries from direct trauma, such as shoulder dislocations, fractures, etc. The digestive and urinary systems are under control of subconscious centers in our brain. So when the brain has a self-regulatory mechanism that tries to stop seizures, it basically tries to shut down the whole brain. That's how it stops. Because by the time you have a generalized tonic-clonic seizure, what's going on in the brain that we see on the EEG is basically the whole brain is seizing. So the brain does have its own mechanism to shut it down, but that requires shutting down everything. Well, when it shuts down everything, it also shuts down these subconscious centers in our brain, such as the urinary micturition centers located in the frontal lobe. And this is where our ability to control and hold our bowel and bladder is gone. So actually, when you have a bowel and bladder incontinence, it's not usually during the seizure, it's actually when the seizure's ended, because everything relaxes because the brain basically shuts off. And this can lead to incontinence, unfortunately. It doesn't happen after every single generalized tonic-clonic seizure, and that is true. And we don't really know why some of the patients have this and why some they don't. And not every single patient will have it every single time. So looking at, I think you requested me to look at electrodermal activity. So basically what electrodermal activity is a modulation in skin conductance. Basically it's set secretion. So what happens is during a seizure, the body has a sympathetic response. This is our fight and flight mechanism. Okay, so this is when we get scared or fear. We have a surge of catecholamines like norepinephrine and epinephrine that goes into our body. This can cause sweating. This can cause the pupillary dilatation. This can cause you to lose your urine. So this is that fight or flight mechanism system. So during a seizure, a generalized tonic-clonic seizure, we know that there's a sudden surge of the sympathetic response. And these are seen in the skin via sweat. Overall, these findings, what was found was that right after the seizure, through the seizure, and afterwards, there's an increase in the sweat production on the skin. And generalized tonic-clonic seizures are associated with a bigger change in these sweat glands. So these findings are suggestive that for major changes, this can be related to the cardiovascular system changes. So the same thing that's happening on the sweat is also affecting the heart. And this can be a sign of instability in that system of the subconscious parts of our heart and lungs. Hormonal changes have been linked with generalized tonic-clonic seizures. Probably the most studied hormonal change is something called prolactin, which is produced by the pituitary gland. It's actually something that stimulates milk production in women who are pregnant or after pregnancy. And this is known to also be elevated after generalized tonic-clonic seizure. Other hormones include ACTH, which causes an increase in your cortisol levels a little bit later after the seizure, as well as endorphins and vasopressin. And the theory is that these hormones are due to stimulation of the hypothalamus in the brain during the seizure.
Okay, is that the same ACTH that's used as a treatment for infantile spasms?
Yes.
Oh, okay. Interesting.
Yes, it is. But the mechanism of that action is probably a little different.
Right, okay.
And not quite at the same level.
Okay. All right, so, sorry,
yeah.
Go ahead. If there were a few more things you wanted to cover, go ahead.
No, I think that's all I had to say on that, but I'm sure there will be questions later related afterwards.
Okay. So what about convulsive status epilepticus? That's prolonged seizure activity. Are there any physical consequences outside of the nervous system that are unique to status epilepticus, or are the changes all kind of the same as what you would have with a standard tonic-clonic seizure, but they just are more severe or they last longer?
Right. So generalized convulsive status epilepticus, which is a convulsive seizure more than 5 minutes by new criteria, is associated with a marked increase in plasma catecholamines. That's norepinephrine and epinephrine. This actually, besides the cardiac arrhythmias mentioned earlier during a generalized tonic-clonic seizure, you get further changes in your cardiovascular system, such as hypertension, fast heartbeat or tachycardia. You get the arrhythmias. You also get high fevers because of the shaking so much that the muscles are generating. You can get something called acidosis, meaning where everything kind of becomes a little acidic in the body, and this is because of muscle breakdown from continued jerking or shaking in the clonic phase. And you can get high sugar levels. Eventually, you can get something called refractory convulsive status epilepticus, which can lead to low blood pressure. It can also lead to low sugars, and basically the fluctuations in your blood pressures can actually cause something called pulmonary edema, which is basically when the lungs end up filling with water because of the variations in the blood pressure. These patients do require monitoring in a critical care setting, and continued status epilepticus, especially convulsive kind, can lead to sudden death and cardiac arrest. So it is definitely a little bit more severe, and it's never a good thing.
Right. Okay. So what are some of the potential long-term consequences of repeated tonic-clonic seizures on different bodily systems? If you've had, dozens or even hundreds of these seizures over the years, what are some of the long-term consequences you might see?
So since we're staying out of the brain for now, I won't comment on that. But besides the musculoskeletal problems from having repeated injuries, we mentioned arthritis, neck pain, back pain, chronic aches and, pains from, shoulder dislocations, ligamental damage, arthritis in these joints. These are some of the long-term side effects from patients who have this, and they may not be obvious, seen on X-rays or MRI scans. I also have patients who have serious burns, so scar tissues that form, and they have problems with that. We're going to talk about it in a little bit, but definitely you can have development of something called cardiomyopathy, where basically the muscle tissue in the heart can be changed if you have associated like arrhythmias, for example. And then obviously, the worry is for the risk is increased for SUDEP the longer that you have these type of generalized tonic-clonic seizures that are not affected. And the most obvious changes, I would say, that we run into in clinic is that patients do complain about brain dysfunction. So memory, cognition, mood disorders such as depression. These are probably the most common sort of things we really hear about in clinic, but that does not mean that there are other injuries elsewhere associated with these generalized tonic-clonic seizures.
Okay. Now, how can some of the physiological changes that we mentioned earlier associated with seizures be used to detect or even predict seizures and then alert the patient or caregivers?
Right. So I think that for clinically speaking on what we have available now, the best thing is the auras. So if patients have auras where they can experience a certain smell, or they have a visual aura, some people have a rising sensation in their stomach or a feeling of absolute fear, those have actually been found to be quite sensitive to predicting seizures. But the problem is that they don't always give you enough time to do anything about them. Sometimes the aura can be literally seconds before the generalized tonic-clonic part of the seizure occurs. A lot of research is going on everywhere in the world between private and academic sectors into looking how to use current technology to predict seizures to alert patients and their caregivers. Unfortunately, a lot of this research is looking at implanting microelectrodes, so the small chip basically into the brain to create early warning detection systems. These are really still in the research phase, and they're not quite developed for commercial use at this time. And there are other problems that they are going to be invasive systems requiring, at least a burr hole or small hole drilled into the skull to implant these chips. So this is not something that's readily available, but maybe something to look for in the future. We obviously know we hear about patients who have seizure docs, where sometimes docs can alert patients about their seizures, but this is not considered by the medical society to be 100% accurate, and it might not work for every single person. So really, it's very difficult right now at this day and age to kind of have any system that predicts seizures with any accuracy. And a lot of times, the only things we can suggest to patients are to really pay attention to what happens right before a seizure, which is why your doctors may ask you or or if you're a caregiver, does the patient have a warning, or do they complain about a warning? And that's kind of what we really rely on these days.
Okay. So even though prediction may be quite a challenge, a lot of parents and family members of someone with epilepsy, particularly people who have seizures during sleep, are interested in any kind of system that can detect a seizure that has already started. So are there ways, I've heard of pulse oximeters and respiratory monitors and things like that can detect changes in those types of things that would alert a caregiver? What do you know about those?
Right. So the oxygen monitors are used, but you have to be very careful using them. Most of the time it would be unlikely to predict a seizure, or most likely the seizure is already happening, and it would alert, for example, the caregiver, the parent, that something is going on. But that's not going to, unfortunately, that only will work if there is a change in the oxygenation level. To have to wear a oxygen monitoring system with an alarm, you'd have to make sure that it stayed on there.
Right,
Same thing with an ECG machine. The same thing with a heart monitor is, you have to be able to place the electrodes on there. And then the other question is, what do you do if you have that machine? So the question is, what are you going to do with the information? Yes, you're going to say, okay, well, my family member likely did have a seizure, but, you still have to end up calling 911 if there is an arrhythmia, or if the oxygen saturation does drop. Do you have oxygen readily available necessarily to treat your family member? So there are some challenges and complications with that, and we don't really know if it's useful to do that at this point, beyond the fact that we can just say, well, maybe there was a seizure or not a seizure.
Okay. So let's talk about some potential side effects of anti-seizure medications and how they can affect various bodily systems, and then what can be done to manage those side effects other than just discontinuing the medication. So I'm going to mention some common side effects, and you can just talk a little bit about what, if anything, can be done about those. What about cosmetic changes, things like gum overgrowth or hair loss or hair growth or those types of things?
Sure. So for gum overgrowth or gum hypertrophy, this is what's commonly associated with phenytoin or dilantin, and it actually is associated with about 50% of patients will have a little bit of this. When we prescribe dilantin or phenytoin, we always recommend oral hygiene and plaque control, which can directly affect the incidence of basically the gum overgrowth. And we definitely recommend seeing a dentist at least once a year. Sometimes gum overgrowth is serious enough that it warrants resection, surgical resection. And in those cases, I think you definitely want to consider actually taking patients off the dilantin because of the recurrence of that. And, it can be quite embarrassing, actually. So you really have to take it on a one-by-one patient, level and see what they think about that. Valproic acid is obviously the most common one that's associated with thickening of facial features, hair growth, hair loss, and acne. And it's associated with polycystic ovarian syndrome. This can be quite embarrassing for young women, and I basically stick to the rule that I basically avoided in this population. And if the patient is again quite embarrassed about it or anything, then you definitely have to take that into account and change the medication. The changes in the skin and the acne and the hair loss, and especially the weight gain, which we're going to talk about, I know, next, it can be really embarrassing and really severe and very difficult to get rid of once you have it. So it's better to think about these side effects prior to actually starting the medications and counseling patients and asking your doctor really, well, what are the side effects and what happens if I get it? Is it going to be reversible? So those are kind of important questions to ask. But as far as treatment for hair loss, acne, thickened skin, stopping the medication may not necessarily reverse the syndrome.
Oh, okay. You mentioned weight gain and weight loss, which are associated with particular medications. And one question I have about that is it necessarily due to appetite changes or metabolic changes or both? And does it really matter what the root cause is of that?
Sure. So valproic acid is associated with a significant weight gain, especially in young women, and studies show that it actually increases abdominal fat deposition, which can be really difficult to get rid of. So it's more associated with metabolic changes. It can stimulate the appetite, of course, as well. Topiramate has been associated with weight loss, and that one is due to suppression of appetite. Doesn't matter. I think for valproic acid it can matter because it's quite difficult to get rid of that weight once you gain it. And really stopping the medication and changing it is key. This is really challenging when it's an effective medication, just like for everything else. If you have amazingly good seizure control, which means 0 seizures, but you're having significant side effects, that has to be taken on a one-to-one kind of basis as well. The topiramate, as far as weight loss, most women don't mind. Some do. Men may mind more than women, and that can be, what I suggest in that kind of situation is to make sure that they stick to a schedule, make sure they eat a healthy diet. And if it's very severe weight loss, nutritional supplements can work as well.
Okay. And also somewhat related, nausea and vomiting. How common is that, first of all? And then how do you deal with that? Because obviously that could be severely impact quality of life if that's a problem associated with the antipsychotic. Right.
So it depends. If it's to the point where it's severely impacting quality of life, that is a problem. I end up generally having these sort of issues in some of my learning difficulty children, children as they become adults and on some of the new medications. And, you can give them a trial of Zofran. I try to reassure patients that if it happens right when at the beginning of when they start taking a medication, it should pass.
Okay.
But if it's severe to the point where they're starting to lose weight, we don't want them to get to the point where they're having nutritional deficiencies. And the question becomes, how good is their seizure control versus do they really want to take another medication to stop the nausea and vomiting? It's very common. Every single anti-epileptic drug is associated with some degree of nausea and vomiting, but it's usually associated with higher doses. So maybe cutting down the dose would, help with some of the symptoms there.
Okay. What about liver damage and kidney stones as possible side effects?
Sure. So the liver is responsible for metabolizing the majority of our anti-epileptic drugs. But some of the medications are specifically significant as far as causing liver damage. And this is, for example, felbamate, which can cause fulminant hepatic failure. You actually have to sign a consent form for this. If we're talking to the point of hepatic failure, we're talking about liver transplant. So this is very serious and should be used with great caution. Carbamazepine and valproic acid and some of the older medications such as phenytoin or phenobarbital can also cause some changes in the liver. And so what we do is we basically monitor at least once a year for changes in the liver function. As far as kidney stones, topiramate and zonisamide can secrete bicarbonate in the urine, basically, and they can cause a bit of acidosis in the body. And this can relate to increased kidney stones, specifically calcium phosphate stones. So what I generally do is if I ask patients if they have a history of kidney stones, most patients don't know the kind of stone they have, unfortunately. But if there is a history of kidney stones, you probably do want to avoid topiramate and zonisamide, especially as first-line agents. in that case. If they do have or have to take it and they do have a history of kidney stones, then you want to definitely make sure that they drink plenty of water and fluids, as terpenoid and zonisamide are partially excreted through the kidneys.
Right. What about immune suppression? I've read that most anti-seizure medications can cause some level of immune suppression, or at least increase susceptibility to colds and viruses and things. Is that
right? So some of the older medications, such as phenytoin, carbamazepine, valproic acid, can cause changes in the immune system. They can also stimulate it to a certain degree. However, the main concern is changes in blood counts, where the immune system can go very low, and this has been associated with valproic acid or lamotrigine. It's very important to monitor, make sure that patients stay as healthy as possible, monitor their white cell count, as far as that's concerned. But in and of itself, except for those causes of those rare changes where the white cell counts, which is our immune cells, go dangerously low, and this is called agranulocytosis, and this requires monitoring and associated with carbamazepine, valproic acid. In general, sometimes immune suppression can be beneficial, depending on comorbid diseases. So, for example, peripheral neuropathy, some type of inflammatory diseases like fibromyalgia. Sometimes the suppression of the immune system can be actually beneficial to the patient. So it's something to know about, but it's not something where you have to, monitor or take some kind of supplement to fight things off. You just have to, make sure that you're taking care of yourself, sort of, in that sort of regard.
Okay. So we mentioned abnormal blood counts. What about other blood changes like salt depletion, things like that?
Sure. So specifically, we're talking about carbamazepine, oxcarbazepine, and the new medication that's called carbazepine, or Actium is the new one. So these are associated with hyponatremia, meaning the low sodium counts, and this should be monitored at the beginning. And then once the patients hit a kind of steady state dose, it should be monitored every so often. And this is important because low sodium levels can cause lots of problems, including worsening of seizures. So you definitely do want to sort of monitor this as well. And but whether you go ahead and treat it with salt tablets depends on what the levels are. Sometimes the levels can drop maybe 5-6 points and then hit a steady state. In that case, you don't necessarily need to treat it with giving salt things. If there is a dangerous drop in the salt, however, and the patients can become confused prior to having seizures, then you definitely want to change the medication.
Okay. A few medications mention possible cardiac problems like arrhythmias or prolonged QT interval. Are those things that are common or fairly rare, and is there anything that's done to look out for those or monitor for those?
Right. So certain types of medications, such as carbamazepine, lacosamide, have been associated with prolonging the QT interval or couldn't be related to cardiac arrhythmias. However, theoretically, anything that blocks the sodium channel, which is carbamazepine, lamotrigine, phenytoin, phenobarbital, a lot of these older medications, they all have theoretical risks, but actually it's interesting enough where the monitoring of them are not actually recommended by the FDA or by in any kind of black box warning. So the lacosamide and the carbamazepine are the most common ones that do have some mention of these changes in the cardiac system, but we don't actually do any kind of pre-screening monitoring here in the United States. Okay.
And lastly, what about bone loss? That can be associated particularly with some of the older medications, but what should patients do to monitor that and then to also potentially supplement?
Right. This is actually one of my areas of interest, looking at some of the newer medications. So the old medications which induce the metabolism of drugs in the liver, which is, for example, phenytoin, carbamazepine, phenobarbital, these medications also induce bone turnover. And this leads to osteoporosis, basically, especially in the long term. So we're not talking about taking it for a week or two. We're talking about taking it for years. And because these were some of the first medications out there, there are tons of patients that are still on these medications. The reason being that they work so well. As far as prevention of this, the main thing you can do is take calcium and vitamin D supplementations. I generally give about 1,200 milligrams of calcium and about 800 international units of vitamin D per day as part of a preventative to help with the bone loss. Generally, I also check a bone density scan every few years. So every 3 to 4 years, I'll check for osteopenia, which is kind of prior to osteoporosis. And in the case of severe osteoporosis, I will refer my patients to an endocrinologist for continued care, and they may require actual treatment with something like bisphosphonates, which is, for example, alendronate, which can help with reabsorbing calcium and vitamin D into the bone and reversing osteoporosis. But just taking something simple as calcium and vitamin D supplementation can help with reducing that risk.
Okay, and do you recommend that for all anti-seizure medications or just the older ones?
The older ones have the most data on there. There was one study in Australia that suggested Keppra or levetiracetam may have some associated bone loss, but this has not been proven in a huge trial. Some of the newer medications also have no data on that, so I wouldn't go overboard with taking it. If you take a multivitamin and you're on a newer medication, that probably would be okay at this point. But the truth of the matter is that a lot of medications have come out in the last 10 years, and it's really too early to tell. There's just not enough data, whereas the old medications have, 20, 30, 40 years of data behind them.
Okay. All right, so moving on to another area of interest for you, let's spend some time talking about epilepsy in women. First, let's talk about the influence of reproductive hormones on seizures, and how do they influence seizures, and are there special treatment options if you have hormone-related seizures?
Absolutely. So let's just talk about the two main types of hormones in women, estrogen and progesterone. In general, estrogen is thought to be a proconvulsive, meaning that it was associated with an increased risk of seizures, whereas progesterone is thought to be protective. So patients who have hormonal seizures, or something called catamenial epilepsy, and that's spelled CATAMENIAL, is a really hot topic, and a lot of my female patients will often ask me if I think their seizures are around their period. So to know what's going on, you kind of have to know what's going on in the menstrual cycle. Estrogen, which is the one that causes the seizure, peaks at ovulation, which is right before day 14 of a cycle, and it's lowest around the time of menstruation. Progesterone is generally high during the second part of the phase, so days 14 to 28, and then it goes down right before menstruation. So the thought process is that it's not so much that the estrogen peak is related to seizures, which is mid-cycle. It's just that the loss of progesterone right before your cycle begins, which is the first day of bleeding, it has more of a neuroprotective effect. And when you lose that progesterone level, your seizures increase. So that's kind of the thought process between these hormones on seizures and around cycles and catamenial epilepsy.
Okay, and are there special treatment options if someone notices that they have this type of epilepsy?
We generally will suggest the mendoxaprogesterone shot, or the Depo-Provera, which is a progesterone-only shot, and it keeps kind of a steady state of progesterone for 3 months. And so sometimes we will try that in our patients who have maybe these types of epileptic seizures.
Okay, and what about things like Diamox? I've heard that.
Yeah, Diamox, so there is some evidence for Diamox for this. It's also been used in other kinds of seizures. So that one, as far as the literature and the research goes for that one, it's kind of mixed opinions there.
Okay.
I've seen it used in different types of epilepsies, not just catamenial.
Okay. And then lastly, what about increasing medications prior to these high-risk areas?
Yeah, absolutely. So what we sometimes will do will be give something like benzodiazepines right before, say, the beginning of a cycle. So starting 3 days before and maybe up to 5 days after. Patients may take about a week and a half worth of clonazepam or cloprazam, or they may even take a seizure medication for that period of time. But this has to be really something where you have to prove it. And so I suggest that what patients do is to kind of keep a diary or a calendar diary of their seizures. And you really want to capture about 3 months worth to really see, do your seizures actually occur around particular parts of your cycle, and show that to your doctor, and then discuss these various options out there.
Okay, great. Why are some certain reproductive disorders, you mentioned polycystic ovaries before, early menopause, infertility, things like that, why are some of those more common in women with epilepsy, and is it related to the epilepsy itself or certain medications or both?
So, so seizures and anti-epileptic medications can compromise reproductive health. So the answer to the last question is that both can cause problems. Women with epilepsy have known to show lower birth rates. They have more frequent problems with menstruation. There's an increased problem in reproductive endocrine disturbances. And just having epilepsy alone alters the neuroendocrine axis, so that we're talking about the hypothalamus, the pituitary gland, which secretes hormones that then act on our sex organs. So all of these things are related to that whole homeostasis thing that we were talking about earlier. We know that patients who have not even just generalized tonic-clonic seizures or seizures, but even if they have an active epileptic brainwave, these can change your hormone levels. So there's an increased risk of these type of endocrine disturbances that are probably directly related to their reproductive organs. Now, polycystic ovarian syndrome, which is linked to valproic acid basically inhibits steroid hormone metabolism. It elevates androgen levels, and it gives rise to PCOS, which is involved in, changes in your insulin metabolism, acne. You get, hairiness or hirsutism, the weight gain, and then this coarsening of facial features. So that can be related to the drug on top of everything else. Infertility. Again, it's all related to these hormonal changes in the neuroendocrine axis. And it's not just having the seizures, just having the epilepsy alone can cause it. But a lot of these seizure drugs, especially the valproic acid, again, can cause further problems for women. Okay, so
is there much of anything that women can do about it other than avoiding
Yeah, absolutely. Avoid. I definitely suggest avoiding valproic acid. This is something that really has been doable in the last, 10 years since the advent of nearly 10 years since the advent of better drugs out there that are, not as effective. Unfortunately, a lot of our community physicians still will go to valproic acid. It is a great drug. It is one of the primary treatments for primary generalized epilepsies. So sometimes you still see patients try it on this as a first-line agent. But really, I think that with the known side effects that we now know, you definitely want to avoid medications that can just worsen everything. And so I'm really a proponent of not trying that as a first-line agent in young women of childbearing age.
Right. Okay. So women with epilepsy who want to become pregnant, what are the things that they can do to increase the chances of a healthy pregnancy and a healthy baby?
Right. So number one, ask your doctor, ask your neurologist. Most women with epilepsy will have healthy children, just by percentage and chance. However, there are a lot of complications that we now know about, and so the best thing you can do is be prepared. The second best thing is to really have some good seizure control. We know that if you remain seizure-free for the 9 months prior to becoming pregnant, your chances of remaining seizure-free during the majority of your pregnancy can be as high as 87 to 88%. So it is really important to speak to your doctor and really plan your pregnancy. Pregnancy planning, I cannot stress enough, is so important. With the advent of the North American anti-epileptic drug study, we know that there are many factors that can influence the ability of your child, from their IQ and their ability to do well in school. And this can be breastfeeding. This can be the type of anti-epileptic drug you're taking. It can be related to doses. It can be related to dose peaks. So you really want to get yourself to a level where you're seizure-free on a minimal dose of your drug, as minimalistic as you can make as possible, or split the dose slowly. And you really have to get counseling for this. And so a lot of my patients are patients from our other epileptologists, and we basically just sit there and we do a lot of counseling. Folic acid supplementation is something that we always hear about. Generally, women of childbearing age who are capable of having children should definitely be on at least 1 milligram of folic acid per day. And this is if you're sexually active, regardless of whether you're on contraception of one kind or another. So folic acid is important in the closing of the spinal cord or the neural tube. And this happens by week 4. And most of us find out we're pregnant somewhere in the second month, by week 6 to 8 weeks. So if you're going to take folic acid, you have to take it prior to getting pregnant. It doesn't matter after week 4 if you're taking it or not taking it. The dosage of folic acid, whether it's 1 milligram or 5 milligrams or 4 milligrams, we don't really know. We do know that 0.4 milligrams decreases your risk of neural tube defects by about 60 to 70%, and when you go to 1 milligram, it's over 80 to 90%. There's not enough research or data out there to suggest, take 1 milligram versus 4 milligrams, so you will see some variability in there. The most important thing is that you take it prior to getting pregnant. This is specifically associated with valproic acid again, but it can be associated with any of the other anti-epileptic drugs. There's so much more to talk about with pregnancy and healthy babies, but it's really a case-by-case basis. Again, the best thing I can advise patients is talk to your doctor, get the information about your specific anti-epileptic drugs that you're on, and really plan out when you're going to have a child. If you're having tons of seizures, it might not be the best time. Really, you want to get as close to good seizure control, which is 0 seizures, as possible.
And what is the actual concern about having a seizure while pregnant? What specifically is the danger to the fetus?
Sure. So obviously, the first, the biggest risk factor is having generalized tonic-clonic seizures. Just a simple generalized tonic-clonic seizure of falling, having a convulsion. Not only do you have physical danger to the mother and the child, which can result in a miscarriage, you also can get changes in the heart and the lungs, which we discussed earlier, and this can lead to decreased oxygenation of the baby, or hypoxia. So this can be really bad for the baby. The other thing is that when you have generalized tonic-clonic seizures, you may have a chance of having a child with lower birth weight. The pregnancy may not meet term. You might have an early delivery. So these are other risks associated with having epilepsy while pregnant. So it's very important, again, to have as good seizure control as possible.
Okay. All right, so let's move on to the immune system. That's thought to play a role in some cases of epilepsy. For instance, people with autoimmune disorders are at increased risk of developing epilepsy. Can you talk about the connection between epilepsy and the immune system, and the role of inflammation in epilepsy? And then one treatment option that's been mentioned in some contexts is intravenous immunoglobulin, or IVIG, and talk about the potential risks and benefits of that therapy for certain types of epilepsy.
Sure, absolutely. So, so in general, these sort of epilepsies should be something that doctors consider in patients who have a sudden onset of epilepsy, especially in young people where they didn't have a history of seizures before, and then they present with partial seizures or generalized seizures, and so and then they can have also other changes, including psychiatric or behavioral changes or changes in electrolyte homeostasis. And so I think probably one of the more famous books out there by Susanna Cahalan, which is Brain on Fire, which is a fantastic, actually, book related to her own experience having something called anti-NMDA autoimmune epilepsy, is a good example of this type of epilepsy. So you really have to find the connection. So the thing is that basically the body forms these antibodies, which is these immune cells, that are somehow thought to be related maybe to having, for example, an underlying tumor or a cancer, and then it attacks the brain. And it usually attacks the temporal lobe, which is why you get these psychiatric manifestations and the seizures can be so severe. In general, these patients fail to respond to anti-epileptic drugs, and there can be a delay of diagnosis, months to years, associated with this. And, we always kind of say, well, patients in psychiatric wards that have seizures, they were fine one day and all of a sudden they develop this kind of subacute progressive psychosis, may very well have had some kind of these autoimmune epilepsies. So when you look at the spinal fluid and cerebrospinal fluid during lumbar punctures, or if you see their brain MRIs, you will see inflammation sometimes related to these, and sometimes you don't. So basically the body attacks itself, causing this inflammation in their brain tissue and related to the epilepsy. Like I mentioned before, the anti-epileptic drugs generally fail to treat these, and so we do use something called intravenous immunoglobulins, which is basically, immunoglobulins basically the big proteins we form to fight our own infections. And IVIG is basically pooled immunoglobulins from thousands of blood donors. And it has been actually shown to help in these cases that remain refractory to normal or traditional, I should say, anti-epileptic drugs related to this. And I would definitely suggest that patients who fail to respond to traditional anti-epileptic drugs be given a course of this as a trial.
Okay.
The potential risk of IVIG can be anaphylaxis, so just having a allergic reaction. You can sometimes get an aseptic meningitis, meaning that you can have a meningitis that's not bacterial. It's just a kind of inflammatory response. You can also have changes in cardiovascular systems because you're pumping large amounts of protein basically back into the bloodstream, and this can cause changes in blood pressure and as well. So those are some of the risks associated with IVIG.
And how common are these types of epilepsies? Are these fairly rare, or is this something that we're finding out is more common than we thought before?
I think we're finding them more common than we thought before. This is a very hot topic in epilepsy. There are a lot of articles coming out where physicians are looking at their practice and going backwards and doing autoimmune workups in lots of cases where they have refractory epilepsy, or if a patient's only developed an explosive sort of epilepsy where, like I said before, they're fine and all of a sudden they're having convulsive status epilepticus out of the blue. There's no structural lesions. There's no warning. Right. So we're seeing a lot of these kind of pop up. And this is really something that's come up in the last 10 to 15 years with the work of Professor Dalmau at UPenn, and now he's in Spain, in Madrid. So, like I said, the most famous being the anti-NMDA receptor encephalitis that's associated with these things. Now, the question becomes, well, why do these develop? So, sometimes a lot of these will be found that there's an underlying tumor. So, for anti-NMDA, for example, you'll hear of patients having ovarian teratomas, which are these tumors that grow in ovaries, also associated with other types of tumors that are out there. So you really have to have a physician who's suspicious, and you have to have, that's kind of how it seems to work, is that you really have to have this suspicious sort of inclination to test out patients for this. And there are other, usual signs and symptoms that are associated with these. Then more and more we learn about them.
Okay, great. So we mentioned SUDEP earlier, sudden unexpected death in epilepsy, and although the exact cause is unknown, cardiac arrhythmias and respiratory dysfunctions may be involved. Can you talk about the possible mechanisms behind SUDEP and what, if anything, people can do to reduce the risk?
Right. So as you mentioned, cardiac arrhythmias, respiratory dysfunction may be involved. The reshaping of the heart, perhaps from constant recurrent seizures, can be also associated. There is maybe a depression of our autonomic nervous system, which is the system that's basically on autopilot and regulates our blood pressure. And this sometimes can be less regulated. And then seizure-related respiratory failure can also be associated with it. What we do know is that the risk factors for increased risk of SUDEP include male sex, a younger age of epilepsy onset, a longer duration of having epilepsy, and then frequent generalized tonic-clonic seizures and polymedication therapy. And the polymedication therapy is likely related to how difficult the patient's epilepsy may be. So they may very well have refractory seizures, be on multiple medications, and that can also increase your risk. In order to reduce the risk of SUDEP, your goal and the doctor's goal should be seizure freedom. Right. So that is kind of what we do in this kind of sort of situation where, especially if there's a strong family history of SUDEP, you really want to hit zero seizures, if at all possible, to reduce your risk of SUDEP.
And is there much known in terms of genetics? I know they're looking at certain genes may be related to an increased risk of SUDEP. Do we know much about that yet?
This is very interesting, actually, as far as genetics and genes. They're still looking for this, and there are a lot of genes that are available. But whether they're all associated with it 100% of the time, not much is known at this point.
Right. Okay. So another emerging concept in medicine is that of the microbiome gut-brain axis. So it's speculated that the makeup of one's gut microorganisms can play a role in the development of certain neurological or psychiatric disorders such as MS or autism or schizophrenia. I haven't seen any link in the literature specifically between this and epilepsy, but is it reasonable to think that a link could be found in the future, at least for some types of epilepsy? And then if so, is there any harm in exploring nutritional or probiotic approaches, particularly if the cause of your epilepsy is unknown?
Right. So you're absolutely right. There is actually nothing on microbiome gut-brain axis in epilepsy as yet. What we do know is that research in mice has been shown that when they have no gut bio, they have a reduction in anxiety. They do better on their stress tests. And this can be related to irritable bowel syndrome, inflammatory bowel diseases, etc. There's no evidence quite for the effect on the central nervous system at this point. But you can postulate that if there's a change in the homeostasis of neuroendocrine function, then seizure control can be related to it. Literature searches in, so we talked about microbiome and probiotics and stuff like that, but gluten, which is really a favorite topic of a lot of people, which is related to celiac disease, which is intolerance of gluten, has been reported in certain types of seizures like occipital epilepsy, but this is not really proven. I think there was one study that looked at 90 children who had occipital epilepsy, and only 2 who were shown to have gluten sensitivity. UCLA published a study last year in May that women who did not eat probiotics at all had a decrease in emotion and sensory-related areas in cognition on functional MRI studies. But this is really just a proof of concept study, and I think it's way too early to really come to any sort of conclusion about the actual effect of this kind of probiotic neuroendocrine system on seizure control. I guess it won't harm you, but I, urge everything in moderation, and, everyone should pursue more of a balanced diet rather than, going to extreme levels at this point.
Okay. So we've covered a lot. I want to open it up to questions now. So who would like to get us started with some questions?
Yeah, thanks.
Go ahead.
Hi. I was just writing down everything that you were saying. I came in about 20 minutes after you started, and what I caught was the part when you said that women can get acne, weight gain, hair loss, and that. What part was that you were talking about?
Yeah.
What's your question, Kathy?
Did you have a specific question?
I said what's been happening with me is everything that you were saying, that a woman can get weight gain, acne, hair loss.
We're talking specifically about polycystic ovarian syndrome, which is increased in women with epilepsy, and it's really exacerbated by taking valproic acid or Depakote or some variation of that chemical. And was there a specific question furthermore?
Well, it's my periods have stopped, and thing I don't know is the different side effects and stuff that can be with seizures. You said all those can be caused by it, but can it be caused also by menopause? And sometimes too, like you said, pains in your legs, your back, and all that. I wasn't sure if it was from menopause and that. And when I go to the doctor about it, they said, well, because of your age and stuff, it's not about your seizures. It's because of your age and your menopause and stuff. So it's a little bit a half and half. You don't know if it's, or I should say, I don't know if it has to do with the menopause or if it has to do with my seizures.
And probably, truthfully, a combination of both. I'm not sure that menopause necessarily explains, having hair growth or hair loss, coarse facial features and acne. But, it's definitely changes in your hormones. If you're actively having epilepsy and you're at that age of having menopause, or you're perimenopausal or going through menopause, then certainly your symptoms will be exacerbated at this time. Really, the way to counter this is to see whether you can get symptomatic relief. The only way to rule out epilepsy would be to see whether, number one, are your seizures controlled? Are you at 0 seizures, basically? And if you're not, then it's going to be really hard to differentiate between changes from epilepsy and changes from menopause. I don't know if that answers your question or not.
Well, also too is the doctor, my regular doctor. He's the one who gave me clozapam, and what has been happening with me is everything on my left side of my body has been hurting me. This morning when I went to to get my hair done, and I started shaking all around my neck. My hands were shaking, and that's never happened to me. But as a side effect is clozapam is shaking, and it's just that it gets me frustrated and gets me worried, and that leads to depression with me, and I'm sleepy and tired all the time. I don't know if that has to do with the weather, but it's everything that you've said is a little bit of half and half of what's occurring with me. And
no, I can understand. Well, clozapam, I think that's what you were saying was clozapam or Onfi. Is that correct?
Clozapam.
Clonazepam?
Clozepam.
Clozapam. Okay. So that is a benzodiazepine, and that can definitely cause tiredness and sleepiness. Not associated necessarily with tremor and shaking, though you say that it does. I've never seen it myself, medication, but it probably does. All these seizure medications cause something. At this point, all I can recommend is that you speak to your physician today about what happened today at the hairdresser's. The left side of the body being painful, I don't know why it would just be one side of the body or the other. If that's something that's, all of a sudden out of the blue and new, you also may want to speak to someone who can actually evaluate you. But I don't really know over the phone what I can do beyond that.
Okay. Other questions?
Okay. I don't know if this is really a question or not, but she pretty much described just about everything that I experienced. The valproic acid, I was on Dilantin, valproic acid, and there was another one there, but I can't remember the older ones. I was on a lot of the older ones, Dilantin. Yeah. And now I'm on really heavy doses of things. I'm up to 1,750 of my Capra twice a day, and 200 of Lamictal twice a day. And since I started with the Capra, the weight's come on.
That's great. Yeah. Sometimes the weight comes off and sometimes it doesn't. It depends on how much weight you gain. We were talking like 100 pounds of weight gain. Easily. I am sure, at least one or two people in the audience will have known someone or have experienced themselves. That's great.
I've gained 30 pounds.
Since the Kappa, or you've lost 30 pounds, I thought?
No, I've gained 30 pounds.
Oh, I'm sorry. I thought you said you lost 30 pounds. I apologize. So since going on the Kappa, you've gained 30 pounds?
Yes, ma'am. When my Kappa dose...
that actually I've heard of. It's not actually one of the common ones where it's well spoken of, but actually I have heard of patients who do gain weight on the Keppra as well. And my recommendation is, make sure you're exercising and make sure you're eating healthy. Sometimes it's a matter of appetite stimulation. Keep a calorie count. You can get apps on phones these days, and I don't have any specific one to recommend, but keep a calorie count for about a week or so to see where the issue is, and that might be the best way to kind of regulate and see where you can improve as far as weight gain is concerned. But you're absolutely right. I have seen Keppra cause weight gain.
Okay.
Okay. Other questions?
Nope. Do I just hang up now, or?
Oh wait, no, we still got a few minutes. I'm asking if any other of the participants have questions.
Hi, Russ. I do.
Go ahead.
I have two boys who have epilepsy, and they both started, ironically, around the age of 5, about the same time. One is now 14, and the other one is 11. They both became med-resistant very early on and tried quite a few different kind of medications, and come to find out the IVIG was what ended up working for us. My youngest son has been on that program now for 3 years, and my oldest about 2.5. I guess my question is, because there's not a lot of information in the Grand Rapids area, we're kind of hunting and pecking and going through this process. We were the pilot family for this over at DeVos Spectrum Hospital, and now they've got, I think about 20 kiddos now going through the same process with the same positive reaction to the IVIG and seeing either diminished to no seizures. We still see a lot of discharging at certain times, especially as we come to the end of the month, right before another infusion. But their ability to be able to stay on task, to be able to focus, for cognitive skills have really sharpened since this has happened. And I guess my question is the body ever going to, sometimes when you go through certain treatments, it starts to replicate that? And will they ever be able to wean off or go to longer stretches without having to go every month?
So this is actually really interesting because I'm assuming your boys don't have any known underlying cause of their epilepsy. Is that correct? They never found a reason. They just respond to IVIG?
Right. My doctor did find that they have an autoimmune disorder, and where it is in their thyroid. But their thyroid, when you test it, acts normal. But when they do, and I apologize, I don't remember the test now, it's been a couple of years, they found that there's
antithyroid or thyroxine?
Right, and he said over time that it would actually start to attack that, and it would actually evolve and move up towards, I guess, to the head. And their concern was...
This is tricky because, the thyroid actually is really tricky. It was it Hashimoto's? Do you know if that's of it? It doesn't really matter.
I would have remembered that one. No, it was where he found these antibodies that were present, and I don't know if we caught it early enough or what. I have the test, but
both boys had it, huh?
Both of them, yes.
Oh, that's interesting. So that is interesting. So, the way the IVIG works is that it basically fights the inflammation, that's caused by these immunoglobulins produced by your thyroid, and if you can find the underlying cause. So, for example, if there was a tumor and you could get rid of the underlying primary cause of what generates the immunoglobulins or the autoimmune disease, then you could potentially cure it. So in your case, I don't know. Obviously, the IVIG is very expensive. I mean, we're talking, thousands of dollars per infusion, right? So Correct. It's very tricky. And despite its use, we're still kind of learning patients do respond and which don't. And it's not actually something that we will know whether they'll be weaned off. I certainly hope so. Then the other question becomes, well, should you consider some kind of other forms of immune therapy? So we're talking more, pills and more of a chemo agent, so to speak, if you will, to treat these medications. And I don't think we know enough yet at this point. But that's very interesting about your sons, but I'm glad that they're actually responding to the IVIG. Whether they get used to the response of the IVIG, sometimes we do see that in other types of autoimmune neurological diseases such as like myasthenia gravis, multiple sclerosis, other types of things where we have used these sort of events. But it'll be difficult to say, and it would be interesting to see how they do, and if we could figure out where the underlying production of these autoimmune issues are, then would the consideration be, ablate the thyroid gland and then give your sons, thyroid hormones. They can maintain homeostasis and see if that works. But I don't know the answer to that one.
Are there any centers or sites that are doing a lot more research in this area because of the fact it is, like you said, so fairly new, and they're trying to, trial and error on this? Is there somewhere we could go that could help, provide because our doctor's been very visionary and very open, but, he's getting to the point, too, that we're kind of guessing and going through this process together. And so I know he would love to have some more support as well.
My suggestion is you could try looking at Mayo Clinic's website, looking at the pediatric neurology department there. Over at Children's Hospital of Michigan, have you tried speaking to anyone here?
I know our pediatrician had tried getting some information a couple of years ago when we were going through this, but there didn't seem to be anyone when they called that had any kind of specialty or any kind of more further knowledge.
Right. So there are a couple of new epileptologists, and one of the more what I would say is one of the heads of the Department of Pediatric, and especially specializes in epilepsy, Harry Chugani, Chugani, and Amy Luat, Amee, and then her last name Luat. And you can always go for a second opinion if it's easier to get to Detroit for Children's Hospital of Michigan. And, they're an excellent epilepsy center, one of the better ones in the country. They do, lots of research and stuff like that. Otherwise, Mayo and Cleveland Clinic may be in the vicinity of the Midwest, maybe other options. But I don't really know anyone out there.
Yeah, that's what we were kind of running into. Thank you very much.
Absolutely. Yes, ma'am.
Did the lady hang up that was talking to you?
I think she did. I'm sorry.
No, I'm still here.
Okay. I, of course, don't know everything, but I know I was at Ann Arbor, the Ann Arbor Clinic, and they did a lot with me. I was in there 13 days, and they caught 12 partial complex seizures plus 2 in my sleep. So, that might be they're very good there. Their main purpose is to bring on seizures so that they can see what happens with the brain and so forth, and where the seizures are coming from, and how to deal with them that way. So I just, I hoped you didn't hang up, because I wanted to share that with you. They're wonderful people.
Oh, well, thank you for that. I appreciate that.
Yeah, and we are very, very fortunate in Michigan. We now have 7 comprehensive epilepsy programs, Beaumont being the most recent one that has achieved that status. So, and I know Spectrum DeVos has recently just got a new pediatric epileptologist, and there's another one coming shortly. So it seems like we're really growing in this state in terms of the number of specialists. So we've got a lot of choices here, but like Dr. Zutshi mentioned, there are also choices in the region with Cleveland Clinic and Mayo Clinic and other options. So we have maybe time for one more question. Any other questions? Well, we're going to wrap up the call, so I want to thank you, Dr. Zutshi, for taking on such a challenging and interesting topic, and really appreciate all the time you put into researching this. And thanks, everyone, for joining us this evening. And we do have one more Learn and Share conference call left this year on December 3rd from 6 to 7:30 p.m., and that is on developmental disabilities in childhood epilepsy. So thanks again, Dr. Zutshi, and thanks, everyone, for joining us.
Thank you so much, everyone, for listening to me speak for the last hour and a half.
Thank you.
Thank you. You did a wonderful job. Thank you. Thank you,
Thank
Russ.
you. I appreciate it. Thank you.